And before we dive in, I just wanted to take a moment and acknowledge the reason we're all here, which is that this is the Investor Insight series of North Coast. This is the last session that we have this year. And the whole session has been sponsored by TalentLaunch and Alliance. And we wanted to thank them for not just sponsoring the session, allowing us to convene here, hosting us, but also many of you know Aaron Grossman, who is right there. So I just wanted to give a quick thank you and applause to Aaron and his group. And many of you know we have a special place in our heart for Aaron and what TalentLaunch has done, because that particular company created and spun out, at the time, EmployStream, subsequently Able, which is a company that we invested in and had a terrific outcome with a great group of investors. And it's a really interesting example of not just saying, hey, how can a startup founder create something interesting, but how can a really interesting technology take life in a larger organization that is the voice of customer, that knows the issue, that has the resources to put an initial product and technology together and then help spin it out and get it out. So it's a really neat model. It's something that we're hopeful to do more of, and we're appreciative to be here. I could take a while and give really nice introductions of our great panelists here. I will not do that, and will instead ask them to do a brief introduction. We'll go right down the line, and you'll understand the context. This is also a unique group in that we have probably a handful plus of people in the group who could easily be on this panel because they have phenomenal entrepreneurial experience in healthcare, IT, and digital health. So you're the ones responsible for asking all the really hard questions at the end. Feel free to fire them in there. And it's a small enough group setting, too, that even as I'm asking questions, if you feel something is within context, fire it off. And I think this group is happy to move on the fly. Fair? Kevin, do you mind starting?
Sure. My name's Kevin Von Keyserling. I'm the CEO of ReadySet Surgical, one of the portfolio companies for NCV. I'm also an NCV investor, and I'm very happy to testify that the NCV investment's already paying back. I logged in my banking account the other day and saw a little deposit from NCV. Hey. Yeah, it felt good. Prior to ReadySet, I worked for a company called KeyFactor. KeyFactor's literally right across the street, one of Independence's success stories in a B2B SaaS company. We exited KeyFactor to Insight Ventures about 2 years ago, and company achieved unicorn status. So we were pretty happy about that run, and that all led me in a long way to meeting Todd and joining the ReadySet team. So glad to be here tonight. Looking forward to talking with everyone.
Okay. Hi, I'm Buder Shapiro. I'm Chief Marketing Officer of Vytalize Health, and Vytalize is a value-based healthcare platform that is partnered with Gnomes and a lot of incredible organizations to help bring them into value-based care. We manage $2 billion in medical spend across 36 states. Vytalize actually acquired the startup that I founded, MedPilot, about 1.5 years ago. I'm thankful that North Coast has backed us from day one at MedPilot and now at Vytalize Health. So, cheers.
Good evening, Joel Tompkins. I'm the president of NorthStar Anesthesia. NorthStar is a anesthesia management company based in Dallas, Texas. We're in 27 states, have about 3,000 anesthesiologists and nurse anesthetists who work for us in roughly 200 facilities. I'm also a North Coast venture investor as well, so a pleasure to be with y'all.
I'm Sue Tyler. Over a 15-year career with Medical Mutual, I learned a thing or two about healthcare finance. And I'm now taking what I know about healthcare finance and using it in the early stage business community. I currently serve on the board of 3 different early stage digital health companies. A venture mentor at the Case Medical School, advisor to the alumni fund of Case Western Reserve, proud member of North Coast Ventures, Fund 3, Fund 4, Syndication Fund, and I also support Caduceus Capital Partners, which is a Nashville-based early-stage digital health investor in the sourcing, evaluation, and support of portfolio companies.
Terrific. Well, thank you all for being here. Sue, let's start with you. So you mentioned 15 years on the payer side. Maybe to share for us what the perspective is like to be adjacent to the delivery of healthcare, but obviously a connection point to both the systems, the physicians, and the patients themselves.
Yeah, so the payer's in a weird place, right? You know, healthcare being 20% of GDP is a problem. You have a disconnect between the buyer of healthcare services and the user of healthcare services. Most healthcare plans are funded by either the government or by employers. And the proliferation of the number of plans, all with different rules, different coverages, benefits, reimbursements, networks, the payer's trying to navigate through all of that, trying to provide access to quality care at a reasonable cost, which is virtually impossible, right? When you think about the proliferation of plans, the number of providers, how fragmented the system is, and how complex benefits are. So I think the payers are trying to do their best to, get people the care that they need at the right time, in the right place, put people in the driver's seat, understanding their own health and their own healthcare needs and navigating their own healthcare journey, trying to manage the cost and keep believe it or not, they want to keep the administrative burden down too, because on the payer side, because it's both sides that have this unnecessary friction and waste. So it's a really complicated place to be sitting in the middle of this very fragmented, complex system of reimbursement. So.
Excellent. So Joel, we'll just keep coming down this line. It's probably a gross oversimplification, but NorthStar provides an outsourced anesthesia service to hospital systems, and anesthesia touches a whole host of procedures. So what is it, just so we understand the model and how it applies other places, what is it about anesthesia that lends itself that you can even have the concept of outsourcing an entire function within a hospital system, and where else might that apply?
Yeah, so hospital-based services in general, you talk about emergency medicine, radiology, anesthesia, pathology, and hospitalists. Emergency medicine probably was the first one to be outsourced. And the investment thesis back then was everybody was out of network in the emergency medicine space, and they made a bunch of money. And so then, kind of radiology followed, and then anesthesia, as anesthesia reimbursement went down over a course of years, we're a subsidized industry. 90% of anesthesia groups in this country are subsidized by the hospital in some way, shape, or form. Our net patient revenue never is equal to or greater than our expenses. So over a course of time, hospitals looked at providers like NorthStar, like USAP, like Napa. There's about a $29 billion space out there in anesthesia, and even we're probably in the top 5 largest anesthesia management companies. We are only a fraction of that $29 billion, probably maybe $10 billion. What hospitals found was that it was very, very difficult to understand how to manage an anesthesia department. They really, it's just such a specialized space. They know that 65 to 75% of their operating margin comes from the OR, but what they didn't know was how to manage the anesthesia piece. So they looked to companies like NorthStar and others to help manage that.
Excellent. I imagine it's a combination of process, technology, and just know-how that makes that possible.
Yeah, I think it's also, I'm actually a nurse anesthetist by training, so it's also looking at, how do you utilize anesthesiologists and nurse anesthetists in a ratio and building models that are the most cost effective, for a space that is subsidized. And so, that's where, hospitals lose a little bit of ability to understand exactly how to do that, and where companies like NorthStar come in.
Great. So Matt, you mentioned that you co-founded a company, MedPilot, which directly served independent physician practices. And I have a lot of empathy for how independent physician practices can exist in a world that is so highly regulated, where as a business, a medium-sized small business, you're not making pizzas, right? You're dealing with HIPAA and systems and lives and payers. So maybe just give us a sense of some of the challenges and opportunities that you saw to bring technology that would create value for independent physician practices.
No, it's a good point, and it's been extremely difficult for independent physicians for decades now. The pandemic did not make it easier. Obviously, from negotiating claims to having the right infrastructure, very, very difficult. At Vytalize and at MedPilot, we believed if we invested in independent practices, it would benefit not just us, but overall communities. We think the independent PCP is critical they have the quality, they have the relationships with the patients. I mean, it's everything. And so we try to make it easy to bring that infrastructure into them to allow for success. And most independent PCPs probably don't have a CTO on their team. They probably can't invest in those types of things. And so allowing them to scale in that way can benefit all of us, I really think.
Great. So Kevin, ReadySet Surgical is using software to manage the supply chain for orthopedic procedures.
Correct.
Maybe give us a sense for how software is actually helping have better outcomes, more efficiency, and cost savings in a world which didn't have software as part of it just a couple of years ago.
Yeah, it's interesting. I was talking with the head of orthopedic surgery for Kaiser Permanente in Southern California. And he said to me at dinner one night, it was, we're trying to practice 21st century medicine with a 14th century infrastructure. So if Dr. Walston's going to go perform a surgery on Mr. Cook tomorrow and he's going to replace his knee, he's got to contact Zimmer, the knee manufacturer. They're going to find the rep. The rep's going to go to their trunk, literally their trunk, load up those trays, drive it over to the hospital. Then it's got to go through sterilization, land in the OR on time for first cut. And first cut's critical. If they don't get the first cut right in the first case in the morning, all the surgical procedures going through that OR get delayed or pushed back. So huge problem with the utilization and getting there on time for first cut. And then the software, the other piece of it is making sure that everybody's performing at top of license. So today, labor is very, very tight in a hospital. It's one of the things that's driving up costs through the roof for a hospital. And so they're very focused on trying to make sure that if I've got a surgeon who's focused on knee replacements, that he's not making phone calls trying to track down his medical rep, or it's the OR nurse or the SPD managers. So it helps streamline that whole process. And on the back end, it's doing the financial reconciliation. What was actually delivered to the hospital, does the invoice match what the contract says, and then it resolves the pricing discrepancy. So it helps with the efficiency of making sure things are there in time and make sure the financial reconciliation is correct.
And do hospital systems know they need this and know what to do with it, or is it still a process?
No. So I was kind of amazed before I joined ReadySet, I wanted to go down to a hospital and see how does this actually work today. And I was surprised at how antiquated it was. And it goes right back to what the surgeon said. It's a 14th century infrastructure. They literally have a little logbook. They log this in when it comes in. Sometimes they track it in Excel. The rep handwrites out an invoice, walks it down to AP. I'm like, holy cow! I'm like, we could use some Amazon, warehouse principles in the hospital. So, huge opportunity to modernize it.
Great. And so, Sue, you mentioned that you're a venture partner with Caduceus Capital. Can you give us a sense of what you're looking for at the early stages as you're sourcing and evaluating these opportunities, to give a sense of if these many opportunities you're looking at can potentially blossom into an opportunity like some of the more mature companies we're talking to here today?
Yeah, so I think, you're always looking for companies that are solving the right problems, right? With great teams that have the culture and the resilience to respond to the market and adapt and adjust and advance their products. And, what are the right problems? I'll tell you, like right now, if something, you have so many organizations that want to offer something that's additive to a process or to the cost structure, and it can't be. It's got to be something that's taking cost out, improving outcomes, increasing administrative efficiency, improving the provider or the patient experience, and they have to be able to demonstrate it. I mean, there's so many that there's a promise of this will help, this will improve, but there's no evidence or there's no data to support it. So you're looking for folks that are solving those problems that are C-level priorities. Especially over the past couple years, there just isn't the management time and attention and focus and IT resources that even if you want something to be able to implement it, unless it is priority for the overall organization. So I think you're looking for the right problems, the solid team, the coachability, and kind of the culture, the learning environment, because an early stage company is going to go through multiple iterations, and can they, do you have the right team and the right environment to be able to successfully do that. But no different than North Coast, just a more narrow focus. With Caduceus is explicitly digital health.
Very good. So, Joel, we're in the headquarters of a staffing company. One of the secular trends, not just in life science, but more broadly, is staffing is in a very difficult place between, for systems, between wage inflation, between the, I'd say, intermediation of staffing companies and other systems, getting between sometimes the employees and the ultimate employers. What does it look like from your perspective, and where do you think we're going?
Yeah, well, I can tell you, we're certainly not immune, to those issues. We've had markets where we've had a 40% increase in wages literally overnight. And when you're a subsidized industry, it's very often difficult to absorb those costs. We have to go back to the hospital and amend our contracts or beg, borrow, and steal for more subsidy out of them. I think it's interesting when I look at in our particular case, pre-pandemic we were at about a 92%. We had a 92% employment ratio. 8% was what we refer to as locum tenens. In the anesthesia space, it's pretty common to have about a 10% locum tenens rate. We are actually at 90% today, so we have only changed by 2%. But what we've seen, at least on the anesthesia side, is that hospitals lost a lot of volume during COVID. We saw cases get pushed to ambulatory surgery centers. The hospitals then are going, how do I get those cases back? Well, in my experience, once cases leave, especially to an ASC, where it's a very easy experience for surgeons to actually go in and do their cases, super easy for the patients, those cases don't actually come back. So, I tell hospital executives all the time, they're like, well, why is there a less than 1% unemployment rate in the anesthesia? And part of it is it's somewhat contrived. We've created a capacity issue because we have more operating rooms open than what we should, given the current volume demands at a lot of hospitals and even ASCs across the country. So, what we try to do is, one, provide great patient care, and two, to be, a destination employer. And, that's something that I think a lot of hospitals are doing. You see changes, as you look at how much money was spent on contract labor in hospitals across the country, during COVID, was massive. You saw, traveling nurses making $200 an hour. And then all of a sudden, finally, health systems started getting smart, and they said, why don't we have our own internal travel pool? UPMC did it. Now, if you're in the travel pool at UPMC, it's $85 an hour. If you're an RN, to go to any of their hospitals. Much higher than their top rate, but a heck of a lot lower than $200 an hour. And so now we're seeing a lot of health systems actually expand their internal pools and their own travel pools, which is now, if you see, there was a couple different health systems whose contract labor for month to month decreased 60-70%, because they finally got wise to the fact that, one, we got to pay people appropriately, and two, we have to stop relying on a contract labor pool market that just can literally set whatever rates that they want to. So I think overall, it's a very complex problem, and we saw a lot of people leave healthcare. Nurses who were on the front lines, taking care of a lot of sick patients during COVID who left, and now we're, creating, I think, some opportunities for folks, and being not only creative with jobs, and going back to when I first started as a nurse, you had weekend, programs where folks would just work Saturday and Sunday, 2 12-hour shifts, but get paid for 40. Hospitals are going back to that kind of, situation where they're getting more folks to actually, come back to the table.
Great. All right, so we knocked out staffing. Matt, so next secular trend, right, is just the lack of a needed reliance on place-based care, right? Where you, through Vytalize, are able, and many others are able to offer telehealth services, remote patient monitoring, other ways to engage that are not place-based. And I think the idea was that COVID didn't necessarily make all of that happen. It made it happen faster. Where are we, though, in that continuum? Because it seems like that we're not continuing to go up and to the right necessarily. What are you seeing as far as the interest from both physicians' practices and patients to engage in those kinds of remote services?
It's a great question, and I thought a lot about it because obviously, yeah, we saw a huge boom during the pandemic. It was critical, it was needed. With that being said, like really where it's going to take a big leap, and the reason why I think we're still in the early stages, is with the Medicare population. Like that's where all the spend is, that's where all the waste is in terms of like needing better quality solutions. And right now, traditionally speaking, Medicare patients are not the most tech savvy. Yeah. However, you know, my parents are 65. I think nowadays that's starting to change. And I think my parents are better at tech than I am. You know, so I think in general, that only has an ability to improve. And that is really going to be the massive boom that we're going to see. It's great when telehealth is like helping us on a convenience level, but it really needs to help with the multiple touch points with Medicare population in order to drive quality and savings. And so I think it's very, very early innings.
Okay. So Kevin, secular trend number 3, all these big hospital systems seem to be losing a lot of money. Can you give us a sense of just, not just what's happening, but how you're seeing that impact either the prioritization of what kinds of projects and initiatives that they're engaging in, and what it's like to work with hospital systems in the current environment?
Yeah, it's a challenging environment. I'd echo what Joel said. COVID was once in a lifetime event, right? And it shut every surgery down in the country. So everybody was sent home, all the hospitals were repurposed to deal with this one thing. We've come out of that COVID spend and surgeries are coming back up, but they've shifted. They went from being in the hospital at the Cleveland Clinic down to the ASC around the corner from your house. They're now replacing your need there versus doing it at the hospital. It's a huge trend that's happening today. Kaiser Permanente lost $1.2 billion last quarter. HCA, the largest for-profit health system, lost $1 billion something Q1. Ascension, 200 hospitals also is losing billions of dollars each quarter. They're all trying to figure out, for the first time, how do we save money? Hospitals in general have been what I would call top-line driven, surgeon driven, meaning that I want to do the very best thing I can to make that pacemaker surgery go well, and I'm going to use the very best tech I can put in there. And whatever is required in that OR, if that means I need to bring in these surgical trays, and think of these trays, they're like, they're, I don't know, about this long, about this wide, and they weigh about 25 pounds each. For a knee, they might bring in 5 trays, just to make sure they had all the right parts. Or if they're doing like a spinal surgery, they might bring in 14 of those trays. Now they're saying, how can I just bring in 4 of those trays so it can reduce my costs? And you're starting to see a shift where the surgeons are starting to listen to the hospital administration on how do we save money, because they recognize it's a real problem. The labor costs that we talked about earlier are just skyrocketing, and everybody's trying to figure out how do we cope with that. It's a difficult environment. But if you have a value proposition that can help the hospital save money, for the first time since I've been working in the space, they'll take your phone call. Before, they really didn't want to talk to you.
Got it. Okay, so Sue, change of pace here. Okay. So last night at about this time, I was bathtub shopping. So we're redoing some bathrooms. We're at Edelman's, actually.
I want to know where this is going. I know,
yeah.
I'm thinking the same thing.
So believe it or not, we're going to one of the questions we talked about. It's a little bit of a long walk. But there were a lot of choices there, and there were price tags in front of each one, right? It was a very transparent process. And healthcare is notoriously not transparent and not comparable. So I'm curious, as you're looking at startups, are you seeing any interesting opportunities or interesting trends for startups that are doing something that, isn't just making more money for the hospital system or helping the doctors, but is actually making the experience better and more reasonable for the patients and their families?
So I don't know that I'm going to directly answer your question, but I will kind of pile on to the problem. You think about healthcare, and there's 70,000 ICD diagnosis codes. And then there's about an equal number of procedure codes. And then there's this infinite number of benefit plans overlaid on top of that. And so if you want to know how much something's going to cost, you need to know all these precise codes. You need to know how many units of anesthesia got used when they're, how the hell do you know that stuff up front, right? You don't. And you go back to the disconnect between the buyer and the user of the service. You overlay all these different benefit plans on top of it. And it's like the, what did Warren Buffett say? When Amazon and Berkshire Hathaway and Chase got together with their Haven venture, when that fell apart, it was something along the lines of, we went to war with the tapeworm and the tapeworm won, right? Like, this is just so complicated. There is not an easy solution that says, here we go, you know, your knee replacement's going to cost X, unless there's a bundled reimbursement system, changes to the reimbursement system, you know, aligned incentives between providers and payers. And we've tried things that, you know, to get the consumer involved, whether it's, you know, high deductible plans or consumer directed, that, you know, hopefully, you know, get the consumer more involved in it. But you get back to it, and the ordering physician often doesn't know the cost of something, you know. So the transparency problems go all the way up through the system. And I don't have any great solutions other than we've got to make this a whole heck of a lot less complicated, because, you know, how much does a colonoscopy cost starts with the question, is it covered? And is it covered starts with the, how old are you? When did you have your last one? Why are you having it? What site of service are you having it at? Who the doctor's performing it? Even before you get to how much is it going to cost, you got to go through all these different and overlay all these different factors. It's a mess. Right?
Have you seen any evidence of progress?
Yeah, I think that, so there's a lot of legislation, there's a lot of things that are seeking for progress, and there's a lot of things, you know, protecting consumers from balanced billing or surprise billings. But, so I'd say progress, but the fundamental problem of the complexity is still there. And it's when you overlay that many layers of complexity on, it's virtually impossible to answer a simple question with a simple answer.
Yeah, I think over the past 2 years, you know, the federal government has done a good job of trying to make pricing transparency better. The problem is, to Sue's point, there's 80 gazillion different codes. Now, what you can do is you can aggregate data. And so what we've seen, because, you know, in our space, you know, I go put somebody to sleep. If I did a really good job, they don't remember me. And if I really did a good job, they have no idea that I worked for NorthStar Anesthesia, and they get a bill from NorthStar Anesthesia and go, eh? And then, you know, now we have balance after insurance issues. So what we try to do is, especially on the ambulatory surgery center side, you know, ambulatory surgery centers, especially the for-profit ones, so the USPIs, the surgery partners, the SCAs of the world, and SCA happens to be owned by an insurance company, they do a really good job of, you get scheduled for your knee scope with Dr. Smith. The next day they're calling you, and they've done something called a 270, 271 transaction, checking what your insurance is, checking what your deductible is, how much you've paid on that deductible year to date, and they're saying, you know, on average, it's gonna cost you $2,200 for the facility fee at this center. And guess what? You have to pay it before your surgery, or we're gonna cancel your surgery. Now, that's a transactional approach to healthcare that I do think that we have to get there, because if not, I mean, I use this adage all the time. You don't walk into Best Buy, pick up a TV, and 90 days later get a bill. You know, and that's what happens in healthcare today. So there has been movement. We are seeing, you know, it's better than it ever has been. And for us, you know, as a provider, we're in all these different states. We have to give a good faith estimate to patients if they call us. We have to.
Has any country figured this out better than the U.S.?
Yeah, single payer systems. You know, you look at the UK. You know, that's definitely easier, a heck of a lot better. But even you look at Canada. Canada's a single payer system with every single province has its own basically health insurance arm. You know, Blue Cross Blue Shield has a massive presence in Canada because of that, because each one has their own system in which they pay providers. Some physicians are actually employees of a province, others are private practice. So, you know, not every, you know, we're pretty screwed up, but, you know, other countries, even with single payer systems, you know, don't have it dialed in.
So I have a follow-up question to that. I think the need and the problem are evident, right? And you guys can, everyone can probably speak to that. I'm curious if we really believe that the solution is tech-enabled, or is that, if we really try to throw tech solutions at this, is it adding to the complexity, right? Is it another layer of Band-Aid?
My personal opinion, it's a tech solution. I mean, again, you have enough aggregated payer data, on actually claims paid, and especially by geolocation, that you can figure out on average what a colonoscopy costs by the zip code that you're going to, have the procedure at, or a knee scope, or a total knee, or whatever the case may be. So I do think that, and there are, folks out there doing this. There are companies, that are out there that are giving really good estimates that are actually aggregating data within a given system. The biggest problem that you get into to trying to provide pricing transparency is not on the outpatient side, it's on the inpatient side. So if you have an inpatient surgery, now it's really, really difficult to figure out, what they're gonna have after the procedure, from if they have any complications or testing. And so that's where hospitals struggle giving good faith estimates because of the complexity of inpatient cases. Now, the number of inpatient cases is going down because more things are going to the outpatient space, but it is a level of complexity that's there.
But aren't you only talking about hefty? If you don't put quality up there, what good is pricing?
Yeah, no, I 100% agree. And so some of the solutions that are out there are actually layering in quality data. And if I were a hospital administrator, I'd want to have my quality data out there. I'd want to have my pricing out there, because I want to draw you into my facility. There's been studies that have shown that patients will go an hour further outside of their way if they know how much things are going to cost them and they know what the quality is. If you walk into a hospital and you're, gosh, my stomach hurts, and you have to have your gallbladder taken out, you don't know who's going to take care of you, coming through the ED. It's an interesting paradigm.
Why would anyone care for as long as there's third-party payers?
Well, because we talk about no surprise billing legislation. No surprise billing legislation was really a balanced billing piece of the puzzle, but to patients it was they didn't know they had a $10,000 deductible, and they also didn't know that their maximum out of pocket was $15,000. So when they got a bill, they were really surprised that they had to pay $10,000 up front. So even though, I mean, really, 2016 when the Affordable Care Act went into effect, that's really when we started seeing a proliferation of deductibles expanding exponentially year over year. Ohio in particular really got hit hard because of all the employer-sponsored plans, where the employers were like, we're going to try to pass on cost to our employees. So I think patients care because their deductibles are so high and they're out of.
Deductibles may be what ultimately causes a user to care. Is that what I heard you say?
Well, I think that it's a big piece of the puzzle because the deductibles are so high.
The high deductibles affect, part of the population for part of their care, but somebody with a very serious long-term chronic position, they're going to be through that deductible pretty quickly. So, where it is real, the high deductibles and the consumer-directed plans, I went on a high deductible plan when my older boy, who's now 27, was in high school. So 10 years or more ago, he got prescribed an acne medicine, and he was taking it for a couple months. No idea what it cost, because I'm paying $10, $15. I'm picking up January 1 rolls around, get to the pharmacy, and they say it's like $800. I'm like, what? I had no idea. And obviously the physician that prescribed it had no idea. I might have said, live with the zits for a little bit longer, right? When I found, and honestly, I thought it was a mistake when the pharmacy did it. I thought, well, I work at the health plan, I'll just pay it, and then I'll fix it next week. No, it's like it was my responsibility. But there weren't the tools in place. There wasn't the dialogue that had me ask my physician, what are the options available to me, and is there a different cost? I would have never thought of having that conversation. I paid $10, So I think it does change the dialogue, but it changes it around a subset of the care, not the very large transplant. Nobody's shopping for the big, expensive things for themselves or their family.
That's true.
The PCP might steer them to the right place, right?
Yeah.
Joel, I hate to pick
Feel free.
Just bury him.
So you could jump into it. But just piggybacking on what Art was saying about really people go into the hospital and they're looking for a wonderful outcome. I mean, the best outcome they can get is for themselves and their loved ones. And this whole idea of staffing and how that's, and all of you are focused on economics, providing a service, a product, or whatever, at lowest cost, driving costs down. At the same time, on the staffing front, you've got outside staffers coming in. Joy, you mentioned that the hospitals were starting to internally manage kind of a system internally where they would kind of not a hit squad, but basically staff critical positions. But for the normal hospital workers that have been there for years, and all of a sudden you superimpose a contract workforce on top of them, I would think that one, culturally, it would be very difficult. I would think possibly the results, the patient results might suffer because of potential resentment on the current staff, nurses, physicians, whatever, of some outside contract group probably, I'll make an assumption, probably getting paid a heck of a lot more than whatever this group that has been there for decades or years is receiving. So resentment, whatever, I mean, I don't know if this, you know, I mean, it's, maybe it works out of this, works out over time, but how does that, you know, affect quality of care? I think it's going to show up in the results of quality of care and patient experience. But I don't know, it's an esoteric question.
No, I think, you know, most folks who are clinicians, you know, quality is table stakes for those folks. Well, there's always resentment on, you know, compensation, you know, and I think that was a huge piece of the puzzle during COVID. You know, what happened was all of a sudden, you know, people who were close to retirement or, geez, I work part-time, I don't need to be in the hospital taking care of these folks who I might get sick and I take COVID home and I get, you know, a loved one sick. They left. It created this huge imbalance, you know, in the workforce that folks took advantage of, you know, and you know, honestly, it's you know, I equate it to like predatory lending. You know, all of a sudden you had, you know, people, agencies that would charge on average, you know, call it $120 an hour, and now they're charging $350 an hour because they can. You know, so you created this massive imbalance where then, you know, I mean, the Cleveland Clinic saw this in some of their cardiac ORs, where all the nurses left because they were like, we're in such high demand, I can go work 6 months and make 3 years' wages. You know, I mean, that is in healthcare, that's really sad. And for someone who, you know, I did 20,000 anesthetics in my career, that was heartbreaking, you know, for me and, you know, most clinicians. So I think the quality piece, you know, and outcomes, we don't see massive changes in outcomes. What you see is churn, right? You see churn with your employees, which for a hospital is a killer. You know, to go and try and hire a new nurse to come into the operating room that has no experience, now you have to train them for 6 months. So now they're not, you know, they're actually not, you know, having any revenue associated with them. They're being trained. And if that person then leaves in 3 months because they had a bad experience, you've created another piece of churn. So I think that's, you know, it's COVID really opened up a lot of people's eyes to that, you know, level of, one, to your point, resentment on wages, and two, the churn piece.
I got a question on the other side of the coin. If you're that shorthanded working those hours and you get somebody coming in, even on a contract basis, wouldn't you be thankful for the help and the support they're providing?
You know, it's you see both sides of the coin. You know, you're oftentimes, yeah, you're really, you know, saying, geez, thanks for even showing up. And during COVID, you know, we certainly had those situations where, you know, we have a lot of business in Detroit. Every single one of our operating rooms turned into ICUs. our anesthesia machines are not equipped to be ICU ventilators, but we had to turn them into ICU ventilators. And you had people sitting there, and so when people came to relieve those folks, they didn't care, who wrote their, who put their paycheck out there. Yeah.
Who wrote the check?
Yeah.
As long as they give it, back to Art's point though, you want quality care.
Yeah.
And hopefully that's all part of the oath that you take.
I think the provider experience is a big part of the quality care too. When you're looking at companies or investments that can improve the provider experience and get the most appropriate person doing the work. One of the horrible things that happen with electronic medical records is now you have clinical folks, tapping keys, right? And adding to their frustration and their workload and, lack of job satisfaction. So I think if there's things that can help us get through some of that administrative crap or, and take that out of clinicians' hands and let them do what they're trained to do, I think that would be better for everyone. And there are some interesting companies that are trying to, improve on the administrative side of healthcare.
Are they AI driven?
So there's all kinds. There's some natural language, things that can take the spoken word and help with the documentation. There's things that can look for things in the medical records. There's some AI driven, recommended next best steps for this person.
It's more voice.
There's
they can
just
say it and it's done.
probably every type of technology is utilized in some different fashion to.
Interoperability in medical records was a huge issue that the government decided not to actually acknowledge. And so when the Epics and Cerners and Meditechs and everyone, MedHost and everyone else under the sun came about, they never mandated that they had to talk to each other. So now if you're a physician and you go to 4 different hospitals, you might have to learn 4 different EMRs and go through the training and try to understand it. And it was kind of it's been a boondoggle.
I could add another layer of issues to the question. I don't know if it's a 14th century issue or a 21st century issue, or both maybe. But it's fraud and abuse claims. How are each of you, are you dealing with those in your companies to help alleviate those issues, Stark Law, things like that? And if so, what are you doing? How are you tackling those issues? Are you using technology? How are you helping ultimately all of us in this room and everyone out there with that too?
Yeah.
I don't touch that at all.
It's not involved, yeah.
Back to Joel.
I can, on the payer side of the world, there's an awful lot of technology, time, effort, money, vendors, brought in to make sure that you're paying the right amount for people that are eligible for your plan, that have the appropriate coverage, and for services that were medically necessary and appropriately provided. There's a heck of a lot of work going on. Interestingly now, I said, taking my knowledge of healthcare finance and using it for one of my portfolio companies, and a company I sit on the board of, works the other side of the house. They work revenue cycle for health systems. And they are using all the newest technologies to do process intelligence, process automation, using AI to rank order, to on the other side, find revenue that should be collected that wasn't collected on the first pass. So, there's technology as well as service companies on both sides of the house. And it's one of the things that honestly frustrates me, because I know both sides of the house and how much effort and money and vendors are brought in on this side to make sure that the right amount's paid, and this side to ensure that the right amount's collected. And you think if you could take all those resources somehow and all hold hands and work together, maybe we could take some waste out of the system. But it's clearly an issue, right? There's bad actors out there. There's improper billings. There's lots of stuff that adds to the cost and the complexity.
I have a question. Shift a little bit. So how do you help healthcare organizations transition to value-based care? Or to ask it another way, how has value-based care affected your companies?
So, it's great. So yeah, our primary objective is working with mostly independent PCP groups, although now we work across the downstream network. I think a lot of the difficulty is the current model of the ACO, Accountable Care Organization. It's pretty difficult to take that on, and if you do it really, really well, you get paid 2 years from now. And so our organization, we work to bring the money more upfront, align it with incentives. And honestly, a lot of the questions that are coming out today, I'm not trying to plug my company, but we believe value-based care aligns incentives with better outcomes and quality. And that's why value-based care is thriving, and that's why we're fortunate to have been doing so well in these past couple of years. I think that it's a combination of technology and services, exactly what you're saying. You need both. You can't just give people a bunch of tech and be like, good luck. Like, you have to work with them and empower them.
So it's working for you?
It's been great. I mean, we've grown over 100% year over year. We've saw a lot of shared savings last year, and we're excited to work with groups like Gnomes and do it again this year. And so, yeah.
Yeah, so if we build on that and think about like bundling and value-based care, how much of a priority or a concern are downstream providers, right? Because you can spend X amount of money in the actual hospital, the actual OR. Patient gets discharged, they end up at home or they end up at a skilled nursing facility, and for whatever reason they don't get the right level of care, then they're readmitted again, right? So, the question I always have is it just better do you make more money out of dealing with the readmission, or do you try to avoid that penalty? I've always thought just, fuck it, I'll pay the penalty and just make the money off the readmission.
Yeah. I love that.
So when there was a total joint program that Medicare deployed, and all of the hospitals were like, geez, we have to start doing outpatient total joints, right? And inpatient stays, let's say, at a hospital on average for a total joint, whether it was a hip or knee, were 3.5 days. And then all of a sudden, this program came out and they were starting to do outpatients, and they're like, wait a minute, our reimbursement dropped. We're getting these patients out, we're doing what we're supposed to do, but we're actually making less money. So it's a real issue.
It's huge. For us, we noticed that, because we're partnered with most of the groups in Ohio, it's less about finding the perfect person to send a patient to. It's more if you take out the bottom quarter of like the really costly providers that are clearly, spending the chunk of the money, you can make a huge impact. So you don't need to send everyone to the perfect doctor. It's more just cut out the bottom, and you can make a huge impact.
What does that mean?
There's, essentially 4 quarters, of quality and care that we look at for our downstream network. We don't need to send every patient to the world's best doctor, but we've noticed that a majority of the cost of care is at that bottom quarter. And so if we can just eliminate sending them there, we see great results.
Yeah. It didn't make the cut.
Yeah.
Well, this last piece might be a good place to wrap up the conversation, because the notion of value-based care, I think, is really interesting and maybe one of the biggest potential paradigm shifts yet to still reveal itself, even though it's happening. The idea of transitioning from fee-for-service to actually paying people to keep patients healthy is such a intriguing and common sense proposition that is still so hard to implement and put process and systems around. But it's neat to see how several of the companies and people here are touching that. And from our perspective at North Coast, that's an area we're really interested in. And just from a thesis perspective within healthcare, IT, and digital health, feel like there are going to be a lot of opportunities where no one can take on the full continuum there, right? But there are going to be a lot of point solutions that, as long as they are interoperable, friendly with larger systems, can actually make meaningful improvements in different aspects there and create value, we'd like to think, for us, the companies, and the patients. So with that, I might just thank our panel for being with us here today, sharing their thoughts and insights. Thank Alliance and TalentLaunch, and Aaron, who may be in the back again, for hosting us here tonight.
And another beer.
Another beer, excellent. So that is a good last point, that the bar is open, there is food left. We hope people will stick around and join us. So thank you.